Hello, I'm Dr. Randall Sechrist, your host for eOrthopodTV. Today we'll be talking remotely once again with Dr. William Seeds. Dr. Seeds is an orthopedic surgeon who practices orthopedic surgery in Ashtabula, Ohio. He is also the medical provider for the Great Center for Sports Medicine in Geneva, Ohio. Thanks for joining us again today, Dr. Seeds.
Randy, thanks for having me.
Dr. Seeds, what I thought we would talk about today is a fairly common injury amongst athletes, and it's what's commonly called the shoulder separation. You and I would understand that as not necessarily a shoulder joint separation, which it's commonly confused with, but a separation of the joint above the shoulder called the acromioclavicular or AC joint. So let's start by discussing a bit about where that joint is, what it does, and what patients need to know about the anatomy of the AC joint.
Sure, Randy. Well, these injuries usually encompass an area that is typically where the clavicle attaches to what we call as the acromion, which is part of the scapula. And it's usually out here on the outside of the shoulder joint. And commonly we may see them in our office where somebody will tell us that they've had a shoulder dislocation when actually what they had was an AC, an acromioclavicular joint separation or dislocation. And these injuries typically are related to how the ligaments that attach the clavicle to the acromion and how those ligaments are disrupted. And that's how we kind of classify the type of injury. And usually I see these type of injuries from a falling injury where they've fallen back and onto the back of their shoulder and their scapula has basically been trapped and the rest of their body is torqued or forced around that fixed scapula, and the clavicle usually pulls off in some fashion.
Yeah, I think this probably is more common in the contact sports like football where you commonly see this. But it can occur with any sort of injury. I mean, horseback riding, those sorts of things. It's not an unusual injury to see at all. You mentioned that we classify these in different stages. Can you go through that for patients and what the classifications mean to an orthopedic surgeon?
Sure, Randy. What we typically will look at these and evaluate these injuries based on 3 grades of injury to that AC joint. The first grade is a grade 1 separation or injury, which is basically what we would call a sprain to the ligaments. Remember, strains are injuries to tendons and sprains are injuries to ligaments. So this is a sprain to the ligament where there's an injury to the ligament where the clavicle and the acromion attach, and there's actually a sprain of those ligaments. There's not actually a tear. In a type 2 injury, we would classify that as where there would be a tear of the acromioclavicular ligament and a slight separation where you could see the clavicle maybe raised a little bit above the acromion. And in a type 3 injury, there's not only an injury, a tear to the acromioclavicular ligament, but there's also a tear of what we call the coracoclavicular ligaments, which they're ligaments that attach the clavicle to what we call the coracoid, which is a bone underneath the clavicle. So you have 2 ligamentous tears that destabilize this clavicle, and the clavicle raises even higher, and that would we grade that as a grade 3 injury.
Now, a little bit about why this is important, and I think a lot of patients again are wondering, okay, what does that mean? Why do we stage these injuries? In your opinion, what's the utility of that classification system?
Well, number one, it gives us an idea of the severity of the injury and how we can treat this injury. More typically, the grade 1 injuries are where there's no complete tear of the ligament. We can rehab those people a little faster and get them back into their sporting activities potentially faster. The type 2 injuries may take a little longer, but usually we can rehab those patients also. And the type 3 sometimes are a little controversial as to if they may require surgery or a conservative method to start with, and what are the benefits of either, and how do you progress with those. So there are some differences in opinions on how to approach those, and what may be best for that patient or athlete at that time.
Well, give us a little bit of benefit of your sports experience in terms of being on the sidelines in football games and that sort of stuff. When you see these injuries on the field, or when a coach or a parent or even a player sees a patient that may have suffered a shoulder separation, what tips you off? What are the things that you look for to try to distinguish whether that patient has a serious problem going on to their shoulder that they need to immediately get x-rays or immediately get into an evaluation, versus maybe a sprain or a strain to the ligaments of the AC joint?
Well, usually, Randy, this is usually on the field, whether it's football or soccer, or from a fall. These people they kind of run off the field with their arm in a position of where they can't move it. You're thinking in your mind that there's a shoulder dislocation. You're not sure until you can get to evaluate them and look and see how that the shoulder is in joint, but they're really having great difficulty with any type of shoulder elevation or rotation. And specifically what I do is I'll do a direct exam, palpation to the joint, and that's usually how you can immediately tell the significance of the injury. You'll be able to feel the offset of the clavicle from the acromion if it's a significant injury, or if it's just a sprain of the ligament, you'll be able to reproduce that pain also. But typically they'll come off the field holding their arm in a position of where they're just trying to protect any movement with that arm.
And when you see these patients in the office, let's say they may have had an injury several days prior, or maybe even several weeks prior, how do you go about trying to determine at that point what's going on with the patient?
Well, we will usually do what I like to do is, with all of my injuries like this, we'll get an x-ray before they come into the examining room. So we'll have an x-ray that's done on the shoulder. I don't typically do a stress view, and that would be an x-ray where you have the patient hold a weighted object, like a pail of about 10 pounds, 5 to 10 pounds usually, to see if you can recreate any more offset of the clavicle. I don't do that. I just do a typical x-ray of the shoulder itself to look at the joint and look to see if I see any offset. And then I will go through the history, and they'll give me the history of the acuteness of, was the pain immediate? Did you have to come off the field? And then the process of how have they done over the last couple days, or sometimes I'll see these patients a week or two later where things just haven't gotten better, or they've been just slowly improving. And so that, in combination with the exam of examining the shoulder and directly inspecting that AC joint and observing it, you can pretty much come to your diagnosis as to the degree of severity of the injury.
And how about associated injuries? Do you commonly see these AC joint separations associated with any other injuries in the shoulder, or is it usually an isolated event?
Most of the time they're isolated events to the AC joint, in my experience, but I have always in the back of my mind, and in my experience, I've seen associated labral injuries with these type of problems, like the so-called SLAP lesions, the superior labral anterior posterior injuries that we've discussed in the past. But that is definitely one thing, especially in the younger athlete, that I'm always cognizant of and trying to keep that in mind as we go along with the exam and the rehabilitation of the patient.
Let's focus on treatment now. When you see this patient in the office, and this is a relatively acute injury, maybe within a couple of weeks or so, how do you proceed with treatment? What choices do you feel like the patient needs to make?
Well, in reference to the severity of the injury, if I see a patient with a grade 1 or grade 2 injury, the first steps I try to do is get them into a rehab process. I don't go ahead with an MRI, I just go ahead with the x-ray at that point, and I get them into rehabilitation of starting to work the shoulder, the rotator cuff, and some specific scapular exercises to get that patient back into a process where we can get them pain-free, and hopefully within a 6 to 8 week time frame we potentially can get them back to full activity with that shoulder. Now if it's a grade 3 injury where I feel there's been a complete separation of the clavicle, then I will go ahead and get an MRI with those patients because I'm more suspicious of a potential labral injury, as you had asked me before, and I'm looking for any other pathologies because usually these are more of a, there's been a more significant blow to the shoulder, and I'm more concerned for those other injuries that could exist there also. And those are the patients then that I, based on the MRI findings, and then we take the next step. And usually I will tell you most of my grade 3 injuries, even though it is a pretty controversial subject, I guess, in our literature about fixation versus non-fixation, I tend more toward the conservative side of treating them in rehab with that also, just letting them know that it's going to be a little longer with their rehabilitation, and that there's potential in the future that joint will give them problems as far as arthritic problems, and then maybe at a later date we can do something to help them. But most of these patients I'm pretty apt to take a conservative route. The exceptions are if I have my baseball pitchers, certain athletes, potentially quarterbacks, tennis players at an elite level. Some of these patients I will discuss surgery with them as far as fixing the clavicle and letting the ligaments heal and taking that step. But again, it's a dialogue that you have to have with the patient and give them the pluses and minuses with both sides of it.
I think the question always comes up in patients with those grade 1 and 2 injuries, whether or not to restrict their activity. Or do you actually give them restrictions, or do you allow them to pretty much do anything that they can tolerate in terms of pain?
Well, not knowing, again, it's a judgment that I make as far as a grade 1 injury and a grade 2. Again, a grade 1 injury is where there's not a tear and I'm suspecting just a sprain, and a grade 2 is where there is a tear. There's always that gray area where you may suspect a grade 1 and yet it's a grade 2 injury where there's a tear. So I kind of take the route of protecting all these people, and I try to keep them from any significant type of lifting or contact activities. And I really base my rehab program for both of those patients on just adhering to those restrictions, but at the same time developing better strength of the rotator cuff and of the scapular muscles to rehab that patient. So at that time, at that 6 to 8 week point, then potentially we can get them back into their sport. I have had some grade 2 or some grade 1 injuries. These are judgments that you make along with the rehab where they've flown through rehabilitation within 2 weeks, and some of these sprains you can get them back in their sport within a couple of weeks. But again, not knowing the significance of every patient and how that affects them, you kind of have to judge that with your rehab, and that's why I'm very close to my therapist and making those decisions as we progress.
Now, what about sling? Do you put patients in any sort of immobilizer or sling right at first?
Yes, that's a good point, Randy. All of the patients, grade 1 through 3, I'll put them all in a sling initially to take the stress off of the AC joint. And we kind of work that through therapy as how we will progress in getting them out of the sling. Typically the grade 1s, within a couple weeks you can get them out of the sling. The grade 2s, they may take you up to 3 to 4 weeks. And the grade 3s, typically I'll keep them in a sling easily anywhere from 4 to 6 weeks, and then progress them on with their strengthening program another 6 weeks after that.
And medications, do you feel that most of these people need some type of pain relievers? Do you use non-steroidal anti-inflammatory drugs like ibuprofen? What's your philosophy on that?
Yeah, that's something that I do believe that the anti-inflammatories are very helpful in those, for that short course of 4 to 6 week time frame, that I will use on all the patients and assist them in their rehabilitation.
Let's talk a little bit about surgery. You mentioned that in some cases with the grade 3 type of AC separation that you will consider surgery in that person. What are those parameters that you go by to sit down and have that discussion with these elite athletes?
Well, those are always tough parameters, I think, to discuss with a patient as far as the surgical benefits of trying to fix these injuries. I do feel there is a case to be made for fixing these type of injuries in these type of athletes who are going to be continually looking at using the shoulder in that fashion and progressing through their sport later in the years, where we're trying to prevent any further degenerative changes of the shoulder, of that joint space. And not, even though we're fixing that joint, are we preventing arthritic changes from happening? We believe we are. Are there potential possibilities that it will continue? Yes, there is, but we're trying to restore that anatomy to its original state. So what I try to do is, I typically will use, there are a couple of ways to do it. People will use screws to screw down through the clavicle into the coracoid to hold it in place so that the ligaments will heal. What I usually do is I'll use like a Merceline tape, and I'll actually make a drill hole through the clavicle and then go around the coracoid and suture it down with the Merceline tape, and then I actually will try to repair the ligament. And that way I don't have to go back in and remove the Merceline tape later. And with the screw, typically you'll have to go back and remove that. I think either way gives you a good fixation. You have to let the patients know that sometimes, though, even though you're fixing this, they still may have a little deformity of the AC joint. Even though you've fixed it, the ligament may not heal in the original state. It may be a little elongated. So you got to let them know all of these factors. And I think the most important thing to tell them, though, is that they still may have a little bit of a bump there, and it may not be perfectly aligned, even though you fix it.
Yeah, the point you brought out about the screw, I think, needs to be pointed out to patients. Normally, I think the recommendation is to remove that screw, because the constant motion leads to breakage of that screw, and once it breaks, you can't retrieve the end of the screw down in the coracoid, and you're sort of stuck with that fragment of metal left in the body. So I do think that you're absolutely correct that if the screw is chosen, that the surgeon probably needs to go back in and take that out after, within a reasonable period of time, like 3 months before the screw breaks. Whereas the other procedures that you talked about with either the bioabsorbable or the non-absorbable, essentially what is just a heavy suture can be left in, and you don't need that second procedure to remove the screw. The other question I would have for you is function. I think it's one thing to try to repair the grade 3 AC separation and get rid of that sort of odd-looking bump that people have after an injury such as that. But what about function? Do you feel that by repairing the ligaments and restoring the anatomy of the shoulder, that a throwing athlete has better function than if he does not have that repaired?
That's a great question. I can tell you by observation in treating many patients with this problem that, and typically in my experience with pitchers specifically, I can't tell you that I've seen a difference in the surgically repaired and the non-repaired athlete, where the patient that has no surgical repair, I've seen them get complete function back and be able to pitch at a high level. Go back to where they were previously, as opposed to the ones that we fixed. But I believe and I haven't had the ability, as these kids move on into collegiate and the professional level, I haven't had the ability to follow them down the road, where I think that the idea of the fixation is we're trying to prevent or to slow down that arthrosis that occurs in that joint, which I think is the problem that can be the bigger problem down the road. And some would argue also that the scapular thoracic mechanics might be a little bit better if you do fix it. But I think the bigger problem would be the arthritic problems that we do know about that can occur down the road with these type of injuries.
Well, a couple of questions about the logistics of surgery to repair an AC joint separation. Do you do this as outpatient surgery?
Yes.
And is this something that the patient needs a general anesthetic for? I'm assuming that that's the case. You put these folks to sleep?
Yes, I'll have them do a general anesthetic, and it's the same day surgery. They'll go home that day, and I'll actually start a passive range of motion program the following day. I'm trying to avoid any type of adhesive problems that can develop from my surgery or from the injury itself. I don't want to see any secondary frozen shoulder or process occur, so I'll start their motion right away after right after the injury and repair.
And what do you think it takes in terms of getting back to full activity after a repair in terms of time? How long do you tell patients to expect to be restricted?
Well, I think that I've seen in my practice, I've seen the patients with my surgical repairs take longer to get back to their activity level. I will usually restrict them for at least 6 weeks before I do really any strengthening process, because I want to make sure that the ligaments have had their best opportunity at healing. So at that 6-week mark, then I basically start into their strengthening program, and at about 3 months, if they're a pitching athlete, at 3 months, then we'll get back into some type of a throwing program where we'll start with distance, intensity, acceleration, and we'll start to work on all those aspects. The key that I want, or what I'm really trying to work on while we're doing that in that second 6-week time frame, is to make sure that all the scapular muscles are firing in sync with the shoulder. That we're really making sure that the scapular thoracic mechanics are just as good as the shoulder itself. And I think if you can make sure that you've addressed that, you're giving that patient a much better opportunity of getting their full recovery back and giving them the full advantage of what you've done with your surgical repair.
Well, I think we've comprehensively covered this topic in terms of discussing what patients need to know about the AC separation and then the treatment options that are available to them. As we close this discussion, is there anything that you think that patients need to know that we have not discussed?
I'll tell you that even though I think we kind of approach these injuries in a fashion in a more conservative fashion, where patients, they see this bump, they feel this bump, and they think, oh boy, I need something done, this isn't good. And it's giving them that reassurance that, hey, listen, we'll get you back to where you need to be with this without taking that jump into a surgical process where you do have the potential of doing very well. The patients that I really need to get a good message across to are those older patients that come in who have separated that joint, either at a grade 2 or a grade 3 injury, who also have historically, you can see on the x-ray, have had an arthritis in that joint. And those patients tend to be a little more difficult to manage, and their expectations are, you've really got to hit home on what the expectations are going to be with this, because they can take a lot longer to rehab. And obviously, because they've had that arthritic joint, they've stirred it up, and they're just not going to respond as fast as you'd like to see them. And those are the patients that sometimes you're going to need to augment other type of therapies to help them to get back to their status. So those are the ones that I find the most difficult to treat.
Well, I think that's a very good point, and I think in our next discussion about this topic of the AC joint, we're going to cover the patient with AC joint arthrosis or wear and tear arthritis of that joint. So I want to thank you for explaining AC joint separation and look forward to our next discussion. Thank you.
Randy, thanks for having me, and I look forward to being back. Thank you.